administration is still pushing back on criticism of his weekend rallies. And it looks like rain is done for the day, but showers and heat are scheduled to make a return. Lisa Meadows is tracking our full forecast.
Now, from Minnesota's most watched station, this is WCCO 4 News.
Good afternoon, I'm Ali Lucia. Thanks for watching WCCO, also streaming on CBSN Minnesota. Several civil rights groups say they're not happy with how Minneapolis Mayor Jacob Frey plans to address police accountability in the city. Marielle Mose was at a press conference this morning where the group spoke out about their concerns. And Marielle, what did they say?
Well, Ali, the group just finished wrapping up their press conference moments ago, and it was several leaders of civil rights activist groups here in the Twin Cities, and they argued that they don't want Mayor Frey to pass on police accountability and reform decisions to the Minneapolis Foundation, which is headed by former Mayor Archie Rybeck. Instead, they want to see a civil advisory council, a civilian board advisory council made up of community members, so that
News from WCCO.
Good afternoon, everyone. Pardon me. We're breaking into programming for the Department of Health daily COVID-19 briefing. So let's go ahead and listen in.
Thank you. Mr. Michael Schalmer, you may begin your conference.
Thank you, Catherine, and thank you, everyone, for joining us for the COVID-19 daily media call for June 22nd. We'll start today's call with a situation report from Health Commissioner Jan Malcolm. Following Commissioner Malcolm, we'll hear from Infectious Disease Director Chris Erzman. After those updates, we'll open it up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Good afternoon, everyone. Thanks for joining us. Around the world, as of this morning, we were at just under 9 million cases of COVID-19 and over 468,000 deaths. In the United States, as of this morning, we had just under 2.3 million cases and just under 120,000 deaths. I was just on a call with the CDC a little bit before this call today, and they mentioned that we've been averaging in the U.S. about 23,000 new cases a day and 675 deaths each day in the last week. And they noted that this has been a trend upward in general over the prior weeks, with certainly some variability between the states. Here in Minnesota, we are at a new total of 33,227 cases. This is up 308 cases from the prior day. There were 430 cases on Friday and 460 cases on Saturday, which reflected a couple of days of increase again from Thursday's cases last week of 360. So we are still seeing that couple days up, couple days down pattern. Our median age of cases is now 40.0 years old, which has continued to trend down over time. We are at a new total, sadly, of 1,384 deaths in Minnesota, an increase of 4 from the day prior. Again, this is the lowest count of new fatalities reported since April 12th. These were 1 each in Anoka, Dakota, Olmsted, and Ramsey. 2 people in their 80s, 1 in their 70s, and 1 in their 60s. There are currently 332 patients in the hospital, 156 of those in intensive care, which is 4 fewer than the previous day. So that stable hospitalization picture from COVID continues to be the case, although, as has been previously mentioned, many of the hospitals still are running at a very high occupancy rate from other business. On the testing front, we had yesterday, on Sunday, 8,670 total lab tests processed, which was a decrease from the prior day's 12,300. We believe this is likely an artifact that many of the laboratories are now, with the slightly more stable situation, working with reduced crews over the weekend, as well as it's reflecting some changes in number of tests collected over the weekend. For example, a significant amount of testing was done in Mower County, That Mower County site was shut down a little bit early yesterday due to impending weather. But we've been gratified by the community's support and interest in testing, and don't have a lot of results to report yet from the Mower County testing. We'll report that in coming days. In Minneapolis and St. Paul, over the past couple of weeks, more than 15,000 people were tested following the mass gatherings after George Floyd's murder. Between the 4 community sites and a lot of testing done by health partners, and want to thank them for their partnership, we were able to meet the need for testing for a lot of people in the community, and we're pleased to see that the positivity rates for those tests following the mass gatherings was under 2%. With that, I will turn it over to Chris Erzman.
Thank you, Commissioner. I'd like to talk about 2 topics that I have mentioned before on these calls, but just today, the Centers for Disease Control and Prevention put out a new MMWR about the effect of the COVID pandemic on use of the emergency room for life-threatening conditions. So I do want to talk about this. We've mentioned that we've seen a reduction in the use of the emergency room during the course of our COVID emergency. And by May, so just through the last month, national data has identified that emergency department visits declined 42% when compared with pre-pandemic use. So, we know that sometimes emergency rooms can be used more for convenience than for need. And so certainly some decline may be appropriate, but what we're seeing with the data is really concerning. And that is that when we look at 3 life-threatening health conditions, so myocardial infarction or heart attack, stroke, and a hyperglycemic crisis or low blood sugar, what we're seeing is significant declines. Emergency department visits declined 23% for myocardial infarction or heart attack, 20% for stroke, and 10% for hyperglycemic crisis when compared with the same time period. So when we looked at the 10 weeks following the declaration of the national emergency for COVID, if we looked at the 10 weeks before that, we saw those significant declines. And if you think about it, a short-term decline of this magnitude in the incidence of these conditions is biologically implausible, especially for myocardial infarction, heart attack, and stroke, especially for older adults. So in other words, we're not seeing this reduction because like we saw with influenza, because everyone was isolating at home, and that really made a difference in the spread of that infectious disease. For these diseases, we would not expect to see this kind of a decline in that rapid of a time period. So it suggests that patients with these conditions either could not access care or were avoiding seeking care. So our concern is that we want to make sure that people who are experiencing signs or symptoms of serious illness, such as severe chest pain, sudden or partial loss of motor function, altered mental state, signs of extreme hyperglycemia, or other life-threatening issues should seek immediate emergency care regardless of the pandemic. So we've mentioned this before, but really wanted to mention it again because it's quite significant, and we want to make sure that we're not seeing deaths that are due to people not accessing care. There has been some look at excess mortality related during this time of COVID. And the concern is that if we have people that are not seeking care for this type of condition, that may be contributing to excess mortality that is not directly related to infection. So I wanted to mention that and make sure that if you are experiencing some of these severe symptoms, that you do seek care, that our healthcare systems are very much designed and ready to care for you safely, despite the fact that we are seeing COVID. And then the other topic that is similarly related, but at not quite the level of urgency, is the importance of making sure, as we've talked about before, that people are still getting vaccinated, and in particular that children are still receiving the vaccines that they need. We mentioned this earlier, but we have seen a drop off in the percent of children who are up to date with their vaccines during COVID because parents are not taking them in for well child, again, deferring because of home orders or other concerns. And we just want to emphasize that as much as we want to make sure that we're practicing social distancing and adhering to community mitigation efforts, taking a test for a well child visit is really very important. Their development, making sure that the opportunity to be evaluated by their healthcare provider, and then have the opportunity to receive vaccinations that will protect them from other infectious diseases. I'm going to put in an early plug. I don't usually mention influenza vaccination this early, but just as we're talking about vaccination, just to be thinking ahead that this year it will be even more important that we have as many people protected from influenza as we can. So with that, I will turn it back over to Mike Schomer.
Thanks, Chris. We will open it up for questions, asking the reporters limit themselves to one primary and one follow-up so we can get to as many as possible. With that, operator, we're ready to take questions.
Yes, sir. At this time, if you would like to ask a question, simply press star, then the number 1 on your telephone keypad. Our first question comes from the line of Jeremy Olson.
Hi, thanks for taking my call. We haven't addressed this as much, but I want to see if the health department's playing any advisory role on therapeutics or treatments for COVID-19, because we're starting to get more and more reports of things that work. There was a study last week out of England showing that steroids might have a benefit at a certain stage, although that only came out in the form of a press release rather than a peer-reviewed study. Is the health department doing any advisories or any other information to clinicians on when to use what drugs and when?
Chris, can you take that one?
Sure.
Chris, we're having some audio difficulties with your line.
While Chris is trying to connect, this is Commissioner Malcolm. Generally, we pass along whatever advisories we get from the CDC or FDA or NIH or any other source. To my knowledge, we are not doing any independent analysis of these treatment modalities. Although I would defer to Chris or Dr. Linfield, who's not on today's call, but we can follow up on that question. Chris, are you back?
Yeah, I just realized I tried to use my handset because my audio was choppy, and apparently I was talking to myself in my office, so I apologize. Can you hear me now?
Yeah, we can hear you better now.
Okay, I'm sorry. So probably you said this very same thing, Commissioner. I just was indicating that Dr. Linfield has weekly calls with infectious disease providers, so they have the opportunity to have conversations about treatment modalities. We haven't put out any press releases related to these things. We get information out more directly to providers, and related to the study that you alluded to from last week, it was very encouraging. But yes, we are also waiting to see peer-reviewed data as opposed to just a press release.
And just as a follow-up on that, what's the situation? Maybe it can be another day if Dr. Linfield's better able to speak to this, but with supplies of remdesivir, has that maintained? There was some discussion of states with upticks in cases getting more of that medication. I didn't know if that came at our expense and if we're starting to receive less of it.
We just had a shipment last week, so we have continued to receive it, but it is true that the higher demand from other states may impact them, but we did just receive a shipment last week.
Thank you.
Our next question comes from the line of Emily Havoc.
Hi, Dan and Chris. Thanks for taking my question. Going back to kids and vaccinations, there was also a news conference this morning with Senator Klobuchar and Children's Hospital saying that there's been a 70% decline in measles vaccinations. I mean, that sounds really scary to me. How concerned are you about that, and what do you think that's going to mean in terms of measles outbreaks down the road? And then as a follow-up, is MDH thinking about doing anything to maybe do more outreach on any of these routine vaccinations to get them to people who aren't coming in?
I'll let Chris take that one, but just underscore that it's a great example of Chris's larger point that as we take our eye off some of these other very, very critical preventive measures, we may see some very, very tragic consequences of that. Back to you, Chris.
Thank you. You're absolutely right. It is very concerning, and I think it's concerning anytime that we see a decline in immunizations, and I think Minnesotans are very familiar with what we experienced in 2017 when we had an outbreak of measles because of under-vaccination. And I think it's even that much more important as we're dealing with a pandemic on top of it. So it's one thing to deal with a large measles outbreak when you're able to focus on that exclusively. But when you're also dealing with a pandemic, we want to make sure that we're taking advantage of every tool we have to prevent other infectious diseases. So yes, a significant decline in MMR coverage is really concerning. And we know that if introduced, that measles can take off anytime we have low vaccination rates. And so we thought less spread in 2017 because we did have a great deal of herd immunity. In the general public, we had some pockets where we had under vaccination, particularly in our Somali communities, but we didn't see a great deal of spread broadly in the community because of that higher level of protection. And we're starting to see that level of protection decline. So it's a really important issue. We have not yet talked about outreach. We're specifically for vaccination, we're really trying to get the word out to parents that it's important that they get their children in and that it's safe to do so, that they can feel comfortable that the healthcare systems have taken the precautions that are necessary so that you can safely bring your child in for well child visits.
Chris, can you confirm, is that 70% decline that the senator is talking about, is that the decline that you've seen? And can you compare that at all to, like, did we see any decline on that scale when we had the 2017 outbreak?
I would guess that the data that the senator is using may be, because the press conference was with children, it may be within their data. We have seen within our own Minnesota data a reduction in coverage for measles-containing vaccine. When we had the outbreak in 2017, the level of coverage within the Somali community was at 42%. So that was well below what I'd like to see for herd immunity. The challenge is when you talk about a 70% decline, that doesn't mean that your rate itself is at 30%. What it means is that you've had a decline, from where it used to be. And I'm not sure what numbers they were comparing because we did not get a data request specific to that. But I will double check and we can get that specific data as to what we've seen in terms of drops with our coverage levels. We can get that to you.
Thank you, Chris.
Our next question comes from the line of Dave Orrick.
Yes, thank you, guys. I want to talk about those 3 life-saving emergency situations you talked about earlier, Chris. And I'm sorry if this information's already been out there, but do you have some Minnesota-specific data, or is this national data that you listed?
Steve, this is the data that I was presenting were national data, but we have heard from Dr. Hick and from others that the same is being seen in Minnesota. And in fact, the data that is included in this comes from 47 states, including Minnesota. And we can certainly check to see if we can provide you with Minnesota-specific data. But obviously, these are not infectious diseases, and so we'd have to check with partners within the agency.
Okay, yeah, thanks. That would be helpful. Is there any possibility that this actually is related somehow to the lockdown? In other words, there's a certain amount of heart attacks that happen from people doing strenuous activities, and if they're sheltering in place, maybe they're not doing that, or there may be other kinds of risk-taking behaviors. It doesn't seem that plausible to me. But are there any other possible explanations for some of these?
I would say that in their assessment, in CDC's assessment of the data, they did not feel like there was a biologically plausible argument to see a short-term decline of this magnitude. So, and it's not, for instance, it's not during January when you might say people aren't shoveling their driveways or something like that. So no, CDC did not feel that there was any sort of rationale for this. And like I said, we did see a dramatic reduction in influenza during the stay-at-home order, and that makes a great deal of sense because we were seeing a significant decline in interactions between people. But that would not have impacted this, and CDC did think about that and said, and their feeling was no, there was not a biological reason for this that made sense, and so hence the great concern.
Thanks. My last follow-up on this point, then, are you seeing, or have you had a chance to look at death certificates and causes of death to see, especially, of course, with myocardial infarction, that might show up to suggest that people are actually having fatal heart attacks?
Oh, so in other words, have we looked at the data? No, we've been focusing on deaths due to COVID at this point. So I don't have that data.
Okay, thank you.
Our next question comes from the line of Nora Hurdle.
Hi, thank you so much. I was wondering if you could talk about the reliability of the tests. I've heard some, I don't know if they're true or not, claims that of folks getting false negatives. Could you talk about what we know about that?
Chris, I'll leave that one to you as well. I think just in general, I think we've said before, no tests are 100% accurate, but there definitely is a range of accuracy in the tests that have been coming onto the market. Chris?
Sure, thank you. And before I answer that, I just want to say one additional addendum for Mr. Orrick, and that is that there, at a national level, there have been reports of excess mortality during COVID with deaths that are not attributable to COVID, so in individuals who did not have COVID, and the thinking is that that may be directly attributable to this decline in seeking care for those very serious conditions. And then to the question about the testing and the whether or not we're seeing false positives, as the commissioner said, no test is 100% specific or 100% sensitive, and certainly depending on the prevalence of disease in a population, so in other words, if you have a population that has very low prevalence, that can also impact the accuracy of the test. And I think what you may be referring to is people who tested negative and then subsequently tested positive. And I want to acknowledge that one of the reasons that we have talked or have said that it's really important for people to be have had about 5 to 7 days, particularly for those individuals who were asymptomatic and going in to get tested following the mass gatherings, that we wanted them to wait at least 5 to 7 days, because you need to get to a point in the course of the illness where you're actually going to be able to detect virus. And so if someone was tested too early in the course of their illness, they may have had a negative test, and then when they're retested later, it's positive. And that does not necessarily have to be an issue with the test or the reliability or the accuracy of the test, but rather when in the course of a person's illness they were tested. So we know the tests are not 100% accurate, because no test is, but I also want to acknowledge that if someone tested negative and then several days later subsequently tested positive, that does not necessarily have to be a false negative. That could have had to do with the timing of the test.
Okay. And do you have a margin of error for the tests that are used widely in Minnesota?
I'm thinking like a 10%, so a 90% sensitivity specificity, but I would want to check that. So yeah, I will refrain, and we will get back to you on that.
Okay, thank you so much.
Your next question comes from Catherine Richard.
Hi. Yeah, my question is about the number of deaths we've seen. I've just noticed that the daily number that's being reported is shrinking a little bit. And I'm wondering what you make of that.
Chris, I'll invite you to comment on this too, but it's certainly an encouraging trend. We're always happy when we see the numbers going in this direction. As you know, they've been kind of down in recent days, kind of bouncing around a little bit, as have the cases down a few days, up a few days. So I think, though, that, and we're just talking about absolute number of deaths each day. So as a proportion of total cases, you might expect that to be influenced by broader testing and more people with fewer or even no symptoms being tested. But in terms of the hospitalization and death rates, that does seem to indicate a positive trend in the severity of disease. Chris?
Yes, I think I agree with what the commissioner said. I think we view it as very positive. And as the commissioner mentioned in her remarks, that the average age of our cases has dropped. So now we're looking at, the median age is about 40 years old. And so what we're seeing is that, as we've said so many times before, initially when we did not have access to widespread testing, our focus of our testing was in our elder population, where we knew that they were the most vulnerable, and we wanted to make sure that we had a handle on what was going on there. And now, as we've been able to expand our testing to a broader population and to younger populations, that makes a difference as well. Because obviously, the older that an individual is, the greater likelihood that if they test positive for COVID, that they would have more severe symptoms. And so the fact that we're able to test more broadly and capture cases that are occurring across the age spectrum, that also makes the difference. But I do want to acknowledge that we've seen really positive impacts in our congregate care settings. And so that is also contributing to the decline in death.
And just to follow up on that, last week Mayo released some data that suggested that the convalescent plasma treatment was safe, although they said, it remains a question as to whether it's effective too. We saw a lower mortality rate with this round of data we collected, but that might have had something to do with the fact that maybe doctors are
getting a better understanding of how to treat patients who end up in the ICU. And I'm wondering if you have any take on that, how we treat the patients in the hospital setting might be shifting as well as doctors and healthcare providers learn more about how this virus functions.
So Commissioner Malcolm, I think that's a great question, and it puts in mind maybe we'll have Dr. Hick and Dr. Lynchill join us on a call to talk a little bit more about clinical insights and how that's changing. It is very much the case that with broader knowledge of the range of symptoms and the things to look for sooner, I think ICU care has become much more informed by just the knowledge that's grown about the impacts of COVID-19 beyond the initial presentation and the thought that it was mostly respiratory in nature. And now there's so much more known about the other ways in which the disease impacts the circulatory system, the immune system, and the like. That I do think it's quite plausible that treatment is more informed by better evidence as we've gone along. But that'd be a great question for Dr. Hick, and we'll bring him onto one of these calls.
Okay, thank you.
Our next question is from Darren Spinston.
Thank you. You mentioned earlier, and this maybe ties into the previous question about the daily death rate dropping a little bit. I believe you said the average rate of a person infected with COVID-19 here in Minnesota is 40, and you can correct me if I'm wrong, Commissioner Malcolm, but is that, in a sense, a good thing, knowing the fact that at least statistically, folks at the age of 40, this COVID-19 virus is a lot less lethal to them than those 75 and older, older averages that we saw previously when the testing was more limited?
Yes, this is Commissioner Malcolm. Absolutely. And as Chris had explained a few minutes ago, just as we're seeing a larger percentage of the total case numbers being represented among broader swath of the population, less concentrated on known at-risk situations, we're getting a picture of how the disease is impacting the broader community. And that is showing up, as you say, in our in the demographics of the age distribution and other things. But as we discussed, the hospitalizations and the deaths, the numbers of people dying of this day to day would reflect something happening in the rate of infection in those higher risk populations themselves, and that appears to be stabilizing as well. And as Chris just alluded to, I was going to make a similar point. The improvements that we've reported in improving infection control and improving management of the spread of disease in congregate settings, we think is showing up in these numbers as well.
And can I just make one clarification? When I started to speak, I said average, but it's actually the median age, which is mathematically different. That's the middle age, not the average. So just to be clear, and that's what the commissioner said in her remarks, but just to be clear that we're talking, the median is 40.4.
Thank you. Appreciate it.
Our next
Operator,
question. Yes, sir.
We have time for one more question.
Our next question comes from Heidi Wigdahl.
Hello, I'm doing a story today looking at caution fatigue, and I'm just wondering what you guys are seeing and advice you could give people as far as how to fight against it, some of the challenges you face in getting that message across.
I apologize, I didn't catch the first word you said. Well, say again, the syndrome?
Oh, sorry, caution fatigue with people kind of letting their guards down and maybe not being so vigilant with their social distancing and mask wearing.
Thank you. Caution fatigue. Okay. Yes, that certainly is something that we see often in public health campaigns, and you hear different terms attached to it. Caution fatigue is a good one. It's a new one on me, but it's descriptive. That yes, people have been hearing these same messages for a long time, and feel as though we've been living in this situation for a very long time, and it's been long, very long in some respects, and difficult in terms of its impact on our lives and the economy and so many things. So not to minimize that at all, but over the course of, this has really all evolved over the course of the last 4 months. So yes, people believe they've heard all the messages, but somehow they may not particularly be fully understanding or appreciating that all of these messages about the need for social distancing and mask wearing and hand washing and the like isn't only about the risk to us as individuals, but it's about our ability, our potential to infect other people with the results of our behavioral choices. So it's not just about, I don't feel that high personal risk, so therefore I'm not going to worry about it. It's my ability, even without knowing it, without knowing that I am infected, my ability to transmit the infection to others, that it makes it so important that people do continue to follow these protective behaviors for our own good and for the good of the whole community.
And I'll just add that, we have started to see some cases, in the younger age group that might suggest that they're just feeling like this isn't a big deal for me, or I'm not worried about it. And yet, unfortunately, we have seen 3 deaths in individuals in their 20s. And as much as we're experiencing caution fatigue now, I think everyone is appreciating the opportunity for more opening up and is very grateful. We want to make sure that can continue. And for that to continue, we all have to be doing our part to make sure that we are social distancing, wearing masks, all of those things, because we certainly don't want to see our cases increase and then have to dial back.
Thank you.
That's all the time we have this afternoon. I want to thank our speakers and the reporters on the call. If you had a question we were not able to address during the call, please feel free to reach out to the MDH Communications Office this afternoon. Have a good day, and we will talk with you again Wednesday.
That was today's COVID-19 briefing by state leaders. Stay with us here on WCCO and CBSN Minnesota.